Ask us, well, how do you know what triggers my AFib? Why is could my AFib be different than my next door neighbor's AFib? And the answer is yes, but statistically most of the triggers come from a few areas in the heart. So it may come as a surprise, but everybody around the country basically does it the same way. So you may either burn the spot, which is the original way we did it, or you can freeze the spot, which I think is a better way to do it, or you can shine the laser beam through a balloon. What you're trying to do is create a circular scar. And the better you can create a circular scar, the better you're going to have a chance of isolating those areas. Now, the procedure is predicated on what? It's predicated on the fact that the triggers come from those 4 veins that empty into the back of the heart. So if your AFib comes from somewhere else, then we've got a built-in 10 to 20% failure rate. So when patients ask us what's the worst thing that can happen with an AFib ablation other than death or stroke, which can happen but almost never does, we'll go over that later. But these procedures are generally well-tolerated, low-risk procedures, but there's nothing worse than sitting down in a, Dr. Jiao will tell you the same thing, there's nothing worse than sitting across from somebody who's had a procedure with the expectation they're going to be fixed, and then they have recurrent AFib. So right now the science in 2018 is not good enough to allow a 100% success rate. So whether you're here or in Boston or San Francisco, those procedures don't work 100% of the time. They work better for patients who have the come and go AFib. We call it paroxysmal or spell AFib. And what's paroxysmal? It means it comes and it usually goes away on its own. So there's patients who are tortured by recurrent palpitations and then it goes away on its own. Sometimes you have to shock the heart back. So the laser balloon is our latest incarnation. Oh, thanks. Is our latest incarnation. And what do we try to do? Why is the laser maybe better? Dr. Jiao was in a very tough case yesterday. I think he got out around 5 o'clock, and he was trying to use the laser to ablate those areas, and he worked. Those who know Dr. Jiao never doubt his work ethic. Dr. Jiao was in there all afternoon shining the laser beam arc around the circle, and then he called me and he said, I couldn't isolate any of the veins. He had to go do some touch-up. But the presumption is maybe the laser beam creates less tissue damage and has a more durable or long-lasting effect. That's why we've done it in 11 patients. We can't tell you what the long-term results are. So that's an update from the last talk we had about the latest technology in AFib. I texted Dr. Jiao today. There's a new type of cryo catheter that it gets ultra cold very quickly. It may be another way to do it, but the common theme of all this is that we're trying to selectively destroy certain areas of the heart that are not critical to the heart function in an attempt to get rid of the triggers for the AFib. That's the common theme behind all the procedures for AFib. So our latest update on the laser balloon, we're the only center in the Gulf South to have the laser balloon, is that we still don't know yet. So we're going to be doing several other patients, and we tell patients we don't know, but the clinical trials are very promising with the laser in that it may give a more durable, long-lasting effect. Now, a lot of patients will ask us, well, what's better? Which one is better? I want the best one. So what do you think the trouble with finding out the best one is that they've never been pitted against one another in what's called a randomized trial. The cryo's been pitted against the radio frequency, which is the heat energy, but the laser's not been pitted against that. So what we'd like to see as practicing heart rhythm doctors is a big worldwide trial where the first patient gets put in the wing where they go get radio frequency or burning energy, the second patient gets the cryo, the third patient gets the laser. Everybody's got a different set of circumstances. The statisticians then tell us at a year what's the best option. We don't know that yet. So that's what's happening in 2018, is that we don't know necessarily the best way to treat atrial fibrillation. So that's the update on the laser balloon. Has anyone here gotten a laser balloon? I don't recognize anybody. Some have been from out of town. We do patients from Lake Charles and the North Shore in Mississippi. So that's the, if you read about the laser balloon, some of you have asked me, they've read it, you've read about it in either in the Google search or things like that. It's just another way to create a circular scar. So as complicated as it is, all you're trying to do is create, it's like making a little incision on your hand. It heals with scar. The nice thing about the scar is that it's an electrical barrier to that, okay? That's all we're trying to do. And the better we do it and the more durable it lasts, the more lasting the effect. But if your AFib comes from another area of the heart, then we could put you through this whole shebang and 6 months later you're back in AFib. So that's the limitation of procedural approaches for AFib. Now the other important news that's come up in the last 3 months is a major study called the Castle AF study. And the Castle AF study showed that if you have a weakened heart muscle, if your heart muscle is weakened for whatever reason, we used to shy away from those patients more because we thought they'd have a worse result. What the Castle AFib study showed is that even with a weakened heart, you may get significant benefit from a procedural approach to AFib. And I think the biggest thing that struck me was that you didn't even have to fix the AFib. You could just have a reduction in the amount of AFib. So that kind of struck me as being a little bit odd. We used to always think we have to fix the AFib, that you have to have no AFib to get benefit. The Castle AF study suggests otherwise. So we may be changing our approach a little bit. In terms of the hybrid convergent procedure, which some of you have had, which is a little bit more radical way of approaching AFib, it's usually reserved for patients who are in AFib all the time. It's a long, complicated procedure. It takes a lot of work. We have now, what, 350 or 360 patients over 7 years? Jen, 350 or 360?
Probably close to, you mean the total tissue, about 5 years?
Uh-huh. It's over 350, right?
No.
No.
It's in the 340 something.
340?
Yeah. The longest one we monitored probably 6 years, 6.5 years.
So that procedure, we think, it's hard to judge how effective it is because patients have been in AFib, some patients have been in AFib for so long, it's not really fair to give an assessment. We've done patients with 10 years of AFib, and those are supposed to be the ones that nothing can work in. So it's hard to really know how effective it is, but it's our last resort type of procedure. And some of you I know have had the hybrid convergent procedure. So when you look at your options for AFib, it's always when we construct a decision tree for AFib. So you come in with AFib, it's basically going to come down to one of several options. Either we leave it alone and accept it as rhythm of choice, okay? We call it the leave it alone option. For the 30% of patients who have no symptoms, sometimes leaving it alone is the best option, okay? So what do you lose if you stay in AFib? Anybody want to go back to our original lessons on AFib? What do we lose if we stay in AFib all the time and you don't have symptoms?
Get tired?
You tend to have less what we call functional capacity. You may do all right sitting at your desk job, for example. But if you try to go walk the mall and keep up with your friend, you may find that he or she's beating you to the punch a lot better. So you tend to lose about 10 to 20% of your ability to push yourself. It could be 20 in some patients and 10 in some patients, and some not much. But you do lose something. You usually lose something. What's the other dark cloud that hangs over staying in AFib? It's the stroke risk. Okay? So a lot of patients believe that if you're on a blood thinner, your stroke risk is 0. That's not true, because if you go back and read the clinical trials, there's always some finite risk of stroke if you're in AFib. The blood thinners take the risk down, but they don't eliminate it. So theoretically, believe it or not, this hasn't actually been shown to conclusion, but theoretically, if you could stay in normal rhythm, your stroke risk would be much better. So what you lose by that option is basically you lose some get up and go, and you condemn, I don't want to say condemned, but in a sense you are condemned to take blood thinners. And blood thinners have their own risk. Okay, these are not benign drugs. We've had we've had deaths on blood thinners. Not a lot, but we've had some. So that's always a warning if you have to take blood thinners. Of course, we've had a lot more strokes. I saw a young Russian seaman today on the West Bank who presented with a huge stroke. He had been an A-Fib for some indeterminate period of time and nobody had picked it up. And he had a massive stroke. And fortunately, the neurologists over there were able to fish out the clot. But not everybody's so fortunate. So we see far many strokes with this than bleeds. Okay, so you're basically trading a stroke risk for bleeding risk. Unfortunately, medicine can't tell you what's going to happen. So if you choose the leave it alone approach, usually it's an asymptomatic patient, you do lose those two things. So that's the first strategy. And any doctor around the country is going to go over through this decision table with you and basically tell you the same thing. So the second major strategy is a pill. Okay? Many different pills for AFib. We call them anti-arrhythmia drugs. And the purpose of the anti-arrhythmia drug is to chemically bind to the upper chamber tissue and make its electrical flow go different, slower, make you less prone to go into AFib. So I'll bet you three-quarters of the patients in this room are probably on an anti-arrhythmic drug. Who's on an anti-arrhythmic drug? Yeah, I don't count, but it's pretty high. So what's the downside of an anti-arrhythmic drug? First of all, does an anti-arrhythmic drug completely get rid of the AFib?
No.
No. Although in some patients it comes pretty good. I mean, some patients are, we call them super responders. As they take one pill, they may go a year, 2 years, and never have an episode of AFib. And then one day it comes back. But there's a misconception that if you take an anti-arrhythmia drug, that your AFib is, quote, fixed. Well, it's fixed for as long as you take the drug, and even then it's not 100%. Now, what's the downside of anti-arrhythmia drugs?
Every other medication you try to take is contraindicated to it. No
That's a good
antibiotics, no.
Well, for some of the drugs, there are interactions that make them impractical to take. They don't always work. Some of them are very expensive, particularly those who take a drug called Multac. Will tell you that it's a very expensive drug. Rarely, the anti-rhythm drug becomes pro-rhythm drug. What does that mean? It means in some patients the AFib gets worse. That's not as well studied, but it does happen. But the thing we worry about is that some of the anti-rhythm drugs may actually create dangerous rhythms in the lower chamber of the heart. We've had one death from a young woman who took a drug called Sotalol. I'm not saying Sotalol is bad, but she had a very adverse reaction to the drugs. So these drugs are not 100% foolproof. And of course, there's the cost of the medication. How often does it happen? It's very, very rare, but it's not zero. Okay? So a common theme you're going to hear from this presentation is that no matter what road you go down, there's good and bad. So the first option was leave it alone, which means you've got to be on some blood thinner. The second option is some type of anti-rhythm drug. What are common anti-rhythm drugs? The one we use the most is also the one that has the most long-term side effects. It's called amiodarone. Anybody here on amiodarone? Amio? Was.
Awful.
We don't like to keep you on it for too long because what's the downside of amiodarone is that it can affect your lungs and liver. It's unusual, but it can happen. So you'd say, why do you even use it? Well, we use it because it's the most effective. We usually use it when everything else has failed. And the other nice thing about amiodarone is it doesn't tend to make the rhythms bad in the lower chamber. It's got a safety profile in some respects that's better. But all these drugs have a lot of interactions. You have to be very careful about how you use them. In fact, a lot of our consults are from cardiologists who are frankly, I don't want to say scared to use them, but they want us to take the responsibility of prescribing them, which is fine. That's what we're here for. Now, so the downside of the drugs is that they don't always work. They can sometimes create their own harmful side effects. Many are costly, and they have interactions. But I think the biggest downside of anti-arrhythmic drugs is that they don't work in everybody. And how many of you have been to the emergency room here at East Jefferson? Not always a pleasant experience. So that means you sometimes have to run back. A lot of patients say, well, I'm going to Europe next week. Can I go to Europe? What they want me to say is that, oh, you're going to be fine. You're not going to have AFib. And it's beyond me or Dr. Jiao's ability to know that. Okay? I've been doing AFib work for almost 30 years. He's been doing it for a long time. We're not that good. We like to think we're that good, but we're not that good. So there's the risk of recurrence. And if you're very symptomatic, if you're a patient who, if they go into AFib, it brings you to your knees. We have patients in the room that it literally brings them to their knees, or they go into heart failure, fluid builds up in the lungs. Not a pleasant thing to go into AFib. So that's the downside of antiarrhythmic drugs. Okay? So what's left? Some type of procedure we talked about where we physically try to alter the upper chamber so it doesn't fibrillate. The current approach is based on targeting the triggers, and you may have heard that under the term pulmonary vein isolation. And if you have pulmonary vein isolation, there's 3 ways to do it. You can burn it, you can freeze it, or you can shine the laser beam on it. Okay, that's basically the 3 ways. Anybody know what the very first procedure for AFib cure was? Jim Cox, back when I was a fellow back in the late 80s, developed a procedure where they opened the chest, and he basically took a scalpel, and of course he didn't do this indiscriminately, he had done it in hundreds of animals, but he cut the atrium into pieces and sewed it back together, and if you do that, the atrium can't fibrillate. Okay, so a lot of patients say, isn't there something you can do to absolutely cure it? And the answer is yes, but you have to put yourself through a hell of a procedure. Now, we've had patients who've undergone the full, what's called the full Cox maze. Jim Cox was the originator. When you hear the term in the literature, Cox maze, that's the curative approach. It works about 98% of the time. It will fix your AFib. We rarely do it, although the surgeon here who does it is excellent, one of the best I've seen. Dr. Brothers does an excellent job, and I've yet to see a patient who's had that have long-term recurrences of AFib. There may be some sporadic occurrences, but long-term recurrence is very, very low. So there is a fix if you're willing to have that done. And some patients, the AFib is so incapacitating they'll do anything. They will have that done. We've had several. Okay? But I'd say the majority of patients that we see who want to undergo a procedural approach undergo one of those procedures. And the cornerstone of this is the pulmonary vein isolation. Typically you come in the morning of the procedure. Several catheters are inserted in the groin. The groin is a nice, safe way to get into the right side of the heart. And then the procedure is done, typically 2 hours, and you go home the next day. A fairly low-risk procedure, but remember, anytime you put something in the heart, it's never 100% zero risk. Success, what do you think the single procedure success rate for a pulmonary vein procedure is? For come-and-go AFib. Anybody want to take a guess? 80? Who says 100? It's not 100.
No, it's 100. No.
It's about 80. It's about 80, depending on some of these procedures are they're dependent on the skill of the operator. Although not so with the cryoballoon. Cryoballoon is fairly easy to do technically. I mean, I think you could train one of the technicians to do it. We wouldn't let anybody do that to you, but it's not technically difficult procedure, but it's roughly 80%. Now, I want to go over one thing, is that when we sit across from you and counsel you, if we had a procedure that worked 100% of the time and had no risk, our decision making would be easy, okay? But you got a procedure that works at best maybe 80% of the time, and you've got some risk, decision making gets a little bit more difficult, because we don't want to do anything to hurt you. I mean, you may like us or not as doctors, but I can speak for Dr. Jiao and myself, we would never do anything to hurt you. But the process of putting you through some of this stuff does entail some risk with it. Why would you take that risk? It's because the AFib is driving you crazy, or you've had adverse effects. Now, I do believe that the AFib ablation is going to become the frontline treatment. Now, when I say 80%, that means all comers, right? So like I always say, and Sharon's sick of hearing it, medicine is great at telling you what happens to 100 people. It is absolutely lousy about telling us what's going to happen to you. So who do we shy away from this procedure? Dr. Jiao will have his own list. I have mine. In general, the older the patient, the success rate drops. At what age that becomes relevant, we have no idea. We've had incredible successes with patients in their 80s, and we've had spectacular failures in patients in their 50s. And for the life of me, I can't always figure it out. Okay? But in general, the older the patient, the more frail the patient is, I'm less likely to put them through that type of procedure. Particularly if you're a lady who's relatively thin, we're worried that the upper chamber of the heart may be more fragile, and the manipulation of the catheter in the heart could result in a tear in the heart. And if you create a tear in the heart while you're on blood thinners, what do you think happens? You bleed into the sac around the heart, and you have a condition called tamponade, which is life-threatening. It has to be alleviated in minutes. So that's our big scare in AFib procedures. So that's basically a broad overview of the different options you have available. So a lot of times I'll tell Sharon, our nurse who's in the room, we'll write that down as I'll call it a decision table, and we'll write it down for you, because we throw all this stuff on you and it gets difficult to remember. So most of the decision making with AFib, we allow patients to help guide us. I mean, one thing I'm very proud of is that we never push anybody. I know Zhen doesn't, I know I don't. We never push you in one direction, okay? There are people that are very much more opinionated than us. If you go, to example, to some places around the country, they'll say, you gotta have AFib ablation. You'll never hear us say that, okay? Because what we're doing when we offer you AFib ablation is we're offering you a chance to trade one thing for another, okay? So that's the overview. We don't have a 100% success rate. Nobody does. Anybody run out of the doctor's office that tells you, we're going to fix it for you. That's the person who's not being honest with you. Because the guy who invented the procedure in France, when you read his literature, he has a high failure rate. Okay? Nobody gets 100%. Okay? So that's for our new attendees to our little conference. That's sort of the overview. And so we're going to take some questions right now, because a lot of times you guys will read things on Google, and we get a lot of interesting questions from one support group to another about new things. I didn't touch on the blood thinner issues. Just a brief update on that. So I saw about a half dozen consults at West Jefferson. I was at West Jefferson, Jen was here today. I saw about a half dozen consults today. And the other consult was from a patient who had a brain bleed and was an AFib. So what do you do then? You can't give them a blood thinner, because the neurologist will say, no you don't, I'm going to send you to jail if you do that. So there are options, since most of the clots form in a little pouch on the upper chamber of the heart, to isolate that pouch. The things you may have heard about are the Watchman device, which we do not offer at East Jefferson. We can go into that why after. We don't offer Watchman. We do offer a procedure done by Dr. Brothers, where he makes a little incision and clips it with a rubber band type device called an AtriClip. A lot of patients will say, well, does it work? What we know in 2018 is that it's non-inferior. It's as good as blood thinner, but it's not better. It never takes the risk of stroke to zero. So you may have questions about that. We have a lot of questions about blood thinners. Nobody in this room, including me, would want to take a blood thinner. Okay? Blood thinners have their own risk. Who's on Coumadin in the room? Who is on a non-Coumadin blood thinner? Much more so. The downside of those are the cost. Okay? And so at that point, I'm going to open it up to questions, and let's see if we can get some engagement. Yes, sir?
You talked about the side effects of amiodarone. How do they test? Do they do blood tests to see if it's causing the side effects? What do they check it with?
Well, let's go over the amiodarone side effects. It can affect your eyes. I'll start at the top and work my way down. It can affect your eyes, and it can cause tiny little deposits in the cornea that don't tend to affect your vision. But if you're driving at night, sometimes you'll get a little halo effect. Rarely it'll affect the retina and affect vision. Second major organ is the thyroid gland. Okay? Amiodarone is loaded with iodine on its molecular structure. Multac looks like amiodarone but doesn't have the iodine. So amiodarone can affect the thyroid gland. It can make the thyroid underproduce. Anybody know the name of that? Underproduction of thyroid is called hypothyroid, in which case you simply replace it. The danger is when it starts overproducing. Basically revs up your metabolic engine, you start losing weight, your heart's revved up. That's actually dangerous, and then the amio absolutely has to be stopped. So thyroid dysfunction is fairly common. Moving down the body, the next big structure is the lungs. One of the more dreaded complications of amiodarone is that it can cause scarring in your lungs. Okay? We rarely see it at low dose, but we have seen it. We have seen fatalities with it at higher dose. So how do you screen for that? You check an x-ray every 6 months to a year, and you do pulmonary function studies. Moving down, it does not affect the kidneys. A lot of patients believe that it's going to affect. It has no effect on the kidneys. It can affect the strength of the muscles. A lot of patients will tell me that they have trouble getting out of a chair because their muscles, their big muscles in the thigh, they're not as strong as they used to be. So it can cause some muscle weakness. Okay? Neurologically, what do you think is its biggest side effect? Tremor. A lot of patients have been, a lot of patients think they have Parkinson's disease because they develop tremor on amiodarone, and it's really the amiodarone. Okay? In a small number of patients, and this is not much less well studied, it can affect some subtle processing parts of your brain. A typical example would be an accountant years ago told me, I used to be able to add columns and numbers, 20 numbers down a column like that. He said, I can't do that anymore. So some subtle things that may do to cognition, that's in a minority. So basically the things we worry about with amiodarone are thyroid, lungs, and I forgot the liver. It can do silent damage to the liver, and you can screen for that with a blood test, but sometimes it can escape you. Now, having said that, we've got a lot of patients on amiodarone. We try to use the lowest dose we can, but we have a lot of patients on amiodarone.
What do you consider a high dosage versus a lower dosage of amiodarone?
Anything above 200 milligrams I consider high dose. Anything below, I always try to get patients to 100 milligrams once a day or once every other day. So above 200 milligrams, and why we use it is because nothing else has worked. It's kind of a drug of last resort. Anybody know what amiodarone was originally developed for?
Rat poison?
No, that's Coumadin.
Yeah, right.
You're the only one taking Coumadin.
Yeah, I'm doing both.
No, amiodarone was designed and was synthesized in France as an anti-angina drug. And in fact, it's rarely used for that. For patients who can't be operated on or whose blood vessels are too small, amiodarone is an excellent angina drug. That's what it was developed for in France. Now, the nice thing about amio is that it's not only the most effective drug, it's also one of the least expensive. It's generic. So you asked me about amiodarone. The general cardiologists, they send us more and more patients. They don't want the responsibility of prescribing amiodarone. They're afraid of the legal consequences if something develops. I'm not casting aspersions. I'm just saying that that's a fact, that they're afraid of the drug. Just like I'd be afraid of treating unstable angina because that's not my specialty. I mean, everybody does what they're good at. But that's a broad overview of amiodarone.
I've been on a defibrillator for 2 years, no problems with A-Fib. But I'm also on amiodarone. Why would I be on the amiodarone even though everything's working fine?
Okay, so a defibrillator is a device implanted to protect you from a dangerous rhythm. A lot of patients who have dangerous rhythms also have coexisting A-Fib. So I don't know whether your amiodarone was prescribed to stop the A-Fib or was prescribed to stop the dangerous rhythms in the lower chamber that would trip your defibrillator off.
The reason I have a defibrillator was because of an electrical problem.
Well, everybody who has any rhythm has an electrical problem. That's a generic.
No, this is beyond the A-Fib problem. It was an impulse that had scar tissue and he was hopping over.
So most patients who get a defibrillator have damage to the heart muscle. Almost without exception, they have damage. There's a couple of exceptions, but almost without exception, have damage to the heart muscle, that's scarring, that's in the bottom chamber.
Yeah,
The trouble is when you have damage to your lower chamber, more often than not you have damage in the upper chamber and you have AFib with it.
so do you think the amiodarone is mainly a precautionary?
I don't know in your individual
Fine,
case
fine,
why they
fine.
prescribed it, but you might want to ask your doctor, did you give it to me for upper chamber or lower chamber problem?
Gotcha.
Yes, sir.
If you have the procedure, what is the likelihood you can come off of all drugs, the blood thinner and the, what other drug do you take to control the AFib?
Would you be happy if I told you we don't know? Okay, so as an important question that's asked all the time, and it's debated at the Heart Rhythm Society meetings. If you have a procedure for AFib, what documentation do you need to provide a safety margin and know you can get off a blood thinner? There are no official guidelines telling you when you can get off a blood thinner. The common practice is that if you have an AFib procedure and you've not had a stroke, is to implant a little microchip under the skin, and if you can go 6 months to a year and demonstrate no AFib, most practicing heart rhythm doctors would probably say it's okay to stop the blood thinner. Now, stopping the antiarrhythmic is a lot easier, because if you stop the blood thinner, what's the worst outcome? You could have a stroke. If you stop the antiarrhythmic, what's the worst outcome? You have a recurrence of AFib, which is, again, I want to repeat in big gold letters up there, AFib rarely, if ever, kills anybody directly. AFib is not going to cause you to drop dead. Some patients believe that because their primary care doctors are scared to live in daylights on them, saying, oh, you got to go have something done, otherwise you're going to drop dead. I've been doing this for 30 years, and I have seen a rare instance where the sudden, abrupt acceleration of heart rate in a patient with pre-existing coronary disease could trigger a cardiac arrest. It's very, very, very unusual. AFib, the dark cloud of AFib is stroke. So the question you have is, I know you're contemplating procedural approach. I want to get off everything. I want to get off all the meds. So that brings up another question. If you look at 100 patients who've had an AFib procedure, what's the outcomes? What's all the cards on the table? In the best outcome, you never have recurrence of AFib. Now, how long do we have to monitor you for that? The rest of your life. That does happen fairly high. That's a high percentage of patients have no recurrence of AFib. Another smaller percentage of patients have AFib that's controllable, but they need an antiarrhythmic on top of it. And you say, well, that's not a win. You still got to use the antiarrhythmic, but you still get benefit if you can maintain normal rhythm. And the rest of the patients, they basically get no benefit from the procedure. It's an absolute washout. It's a total adjunct failure. So, but the question you asked me is, when can you stop it? Well, what we typically do, and Dr. Jiao's practice may vary a little bit from my practice, but I'll wait 3 or 4 months, and if they're having no symptoms and I can verify there's no recurrence, I'll start weaning off the anti-arrhythmia drugs. Why do we wait 3 months? It's because it takes that long for the heart to heal with that circular scar. So I'll wait 3 or 4 months. Some people do 6, some people do longer. I'll stop the antiarrhythmic, but I'll keep the blood thinner gone for at least 6 months to a year. Now, if you're the patient who knows every time they go into AFib, and they have good, what I call perceptual awareness of their AFib, and I can rely on the history, that period of time is generally shorter. If you go look in the 2017, 2018 guidelines for AFib, there's pages of when you start blood thinners. There's nothing about when you can stop them. So every practitioner is going to approach it a little bit different. That's a good question. That's a really good question.
And I think the new guidelines said even you do the procedure itself doesn't mean you can stop the blood thinner. So that means it's in very rare situation where I have a patient who can be monitored for 2 years and then suddenly for pneumonia and then the patient come back with AFib for a couple of weeks and the patient doesn't know. So it's very tricky.
Who would,
when I should?
you know, who scares us the most? If you've had a prior stroke, we're very reluctant, even if we can demonstrate no AFib with a continuous monitor, we're very reluctant to stop it. Because again, AFib can't kill you, but the stroke can take away part of what makes you you. You know, so we're very judicious about who we stop it in, but there are patients in this room where we stop the antiarrhythmics. I know because I recognize them. We stop the blood thinners. So it's a tough question. The expectation is a lot of patients will say, well, I won't do it unless I can definitely come off the blood thinner. A good significant number of patients will be able to come off blood thinners. But there's no guarantee with that. Yes, sir.
Understanding there's no guarantees,
I'll come to you.
you indicated the success rate on the groin injury and doing the balloon is 80%.
I said if you follow patients out to 1 year, roughly 80%. Now, if you're older, that's going to be less. If you're younger, it's going to be higher. It all washes out in the average, so roughly 80%.
How does that compare to the convergent procedure where you come in and do both the atrium and the balloon?
Well, they've never been pitted against another in a randomized trial, but remember the convergent procedure includes the basic procedure with the addition of the lesion set on the back wall of the heart. Dr. Jiao has looked at some preliminary data from our first group of patients. The trouble is, in medicine, to make a broad statement about which one is better, you have to go through a process called a randomized trial. And the purpose of a randomized trial is to eliminate bias. Okay? We think that the single procedure success rate for the convergent is much higher than for the pulmonary vein procedure alone. And so, can I prove that? No. You won't be able to prove it unless you randomize patients, because we could be biased. We could say, well, we think that's better and therefore we're not going to follow you as long, or we're not going to follow you as frequently. So you can fool yourself. That's the purpose of a randomized trial. Our belief is that the convergent, whether you have paroxysmal or persistent, offers you about roughly a 10% to 15% better improvement. But that's our opinion. That's not, if you go to talk to the Ochsner doctors, they would tell you that's BS. Well, they don't do the convergent. They'll say if you do it our way, if you do the AtriCure type procedure, which is a variant of it done through the chest wall, that's better. And if you go to San Francisco, they'll say no. If you do pulmonary vein isolation and you do something else in the appendage, that's better. So what that tells you is that there's no clear consensus. So what you're getting is our opinion through our practice. Randomized trials don't exist comparatively. We firmly believe the convergent is better.
Dr. McKinnie.
The other thing is because convergent, we usually choose, it's not like a paroxysmal episode AFib. We usually choose more long-standing persistent AFib. So there are two different group populations. But I think might be a little bit benefit for this high complex procedure, because when you see the catheter of balloon ablation alone, the persistent AFib successful rate in the 1 year probably 50 to 60. And our data, limited data for the first year, we probably 82.7% for the persistent long AFib, because average for this group patient for at least the persistent AFib for 2 years, 2.5 years. So it's not like a come and goes pattern. And their risk factor, if you use CHART score, their average is 3 above. So I think we select a little bit more difficult patient. And we are not close to the idea we want, but I think probably compared to the catheter alone ablation, this hybrid procedure probably get better result in the first year. I'm still collecting the 3 years data now. I try to find the time I can put the data in, I can present to you guys.
The trouble is, if you were to visit 10 different heart rhythm laboratories, nobody does it exactly the same way. That's the trouble. It's not standardized. Everybody does vein isolation. Some people take the catheter and do more burning. Some do other little nuances on it. I mean, it's just not standardized. But Dr. Jiao, I agree totally that if you've got the come and go AFib, the convergence better, and if you have the persistent AFib, the convergence better.
Pulmonary vein.
But think what you're putting yourself through with a convergent. This is not This is not a walk in the park. I mean, it takes 3 of us, mainly more Zhen, but it takes 3 of us to do that procedure, basically. I'd say me less and less, but Dr. Jiao and Dr. Brothers more and more. Dr. Brothers' part of it takes about 3 hours. He makes a little incision, and we've got to come in the room, everything's got to be re-prepped and re-draped. I mean, sometimes we'll stay in there till 4 or 5 o'clock in the afternoon. And basically, I like to use this analogy, everything we know about fixing AFib, we throw into the gumbo. So we incorporate everything. So it's no surprise that maybe the results are better. But if you were to poll 10 different world-class authorities on AFib, they would say, well, we don't know that yet because it's not been randomized. And they're right.
But as you're doing your work now, is that going into a database somewhere that is going to ultimately create a randomized?
We've done 300 and something. There's other groups have done 300 to 500. Unfortunately, there's no data registry. Now, the company who does this just completed their clinical trial, which was a very difficult process because they did randomize. And see, when people get sent to us, they're sent to us to do something. They don't want us to randomize. They failed everything else. So we don't have the liberty of randomizing. They come to us because nothing else has worked. So that's the trouble. We can't do a randomization. We offer them what we think is the best option. And if you're in another group, you're going to offer what they think is the best option. So all I'm trying to say is that a lot of patients will come back and say, well, I went to this institution, they say do this, and that you're wrong. There's no right or wrong. There's just nobody knows. I mean, anybody who tells me they think they've got the all-knowing about AFib, I'd be worried. Yes, sir?
So if someone's been on Eliquis and Multec, and they feel that they've haven't had an AFib episode for how long a period of time before you would take them on?
I'd go, and you can tell me when you go into AFib, your awareness of it is good, and you've had a procedure?
No procedure.
Okay, so this is a different question. This is not when can you stop it after procedure. This is, at what duration, when you don't have AFib, can I safely stop it? Okay, so what most people would say is, do you know there's a scoring system for risk in AFib? You ever heard of the term CHADS 2 score or CHADS 2 VAS score? A lot of people would advocate it depends on how much risk you have. If you've had a thrombotic stroke from AFib, and we can't tell you for certain that that can't happen again, most people would keep the blood thinner indefinitely. Most.
But suppose a person hasn't had anything, I mean, no problems at all, before he went, his first episode of AFib, and then he starts on Eliquis and Multec. How long a period?
Generally, I would go a year if the risk was low. And what I would say is, don't throw away the blood thinner. If you feel palpitations, go right back on it. So people call that the pill-in-the-pocket approach for blood thinners. Other people would say, we don't know, you've got to stay on it forever. So you'd have a divergence of opinion among different specialists. I'm just telling you what the current thinking is.
Would it make any difference whether you had a procedure as opposed to just taking medication?
I think there's more of a precedent for stopping it after a procedure. The presumption is the procedure is going to make the likelihood of recurrence much lower. Let me give you an example. I had a patient in his 40s who had a couple of binge episodes of partying, and he developed AFib. And we put him on antiarrhythmics and shocked him. He stopped alcohol. He went a year. I felt no problem at all with stopping that patient's anticoagulant because what triggered his AFib, we had an identifiable trigger and he stopped it. I feel better about that patient. Another patient might have thyroid dysfunction. They develop AFib. The thyroid is now resolved. I feel better about stopping anticoagulation. Again, notice in the official guidelines, there's no official recommendation from the American College of Cardiology about what you can do.
What criteria do you use to do a procedure on a patient?
It's usually a patient who has symptomatic AFib that has failed 1 or 2 heart rhythm medicines, and the patient's ability to accept the risk of the procedure. If you come in and say, I don't want to take any risks, then we shouldn't do any procedure.
Well, it shouldn't be there anyway.
Well, there's risk with anything. There's risk, somebody was telling me walking in that one of their friends got killed coming over the causeway.
I
You
gotta
don't
go
think
back
about
to
that,
our
but every time you get in an automobile, there's risk.
Okay.
We don't live in a risk-free world. So,
What was this question? And then I couldn't hear it.
you want to repeat for him?
What are
What's the criteria for doing the procedure?
You know, to accept a patient to do a procedure?
Most patients are sent to us because the cardiologists have noted that everything they've tried has failed, and patients get tired of running to the emergency room, or they're intolerant of the medicine. Some people can't tolerate any of the medicine.
Like, see, like myself, I don't ever know when I'm in it. I don't know when I first had it.
And what percentage of patients do you think? That's 1/3 of patients have no awareness. That's a blessing and a curse. The blessing is that it doesn't bother you. The curse is that a huge number of strokes that wind up on the stroke unit have never had any awareness of AFib, and their first presentation is not AFib. Their first presentation is a big clot to the brain.
I'm on 2 blood thinners.
What's your stroke risk? It's not 0.
No, I didn't say that. I wasn't gonna answer that.
The pill in the pocket strategy, are you saying like when you feel like you're going into AFib, then you take a blood thinner?
There's 2 pill in the pocket strategies. One is for heart rhythm. So let's say you're going to Europe. It's a common scenario actually, and you've had 1 episode of AFib in 2 years, and you're not taking any heart rhythm drug. You've had 1 episode, and you go into Europe and you say, well, what happens if I go into it? We give a single high dose of a drug, usually it's Propafenone. So if you go into AFib, take that 1 dose. The pill in the pocket for stroke is different. That's in a patient where we think they're okay, but just to be as a precaution, they develop symptoms they think are AFib, you immediately take the blood thinner.
And how soon is the blood thinner effective? In other words, if I
So,
take it just right now,
If you
when's it going to
take-
go into effect?
If you take what's called a NOAC, a new oral anticoagulant, examples Eliquis, Xarelto, Pradaxa, Savasa, 30 minutes after you take the dose, you're pretty much safe. That's the nice thing about it. Coumadin, it could be 2 or 3 days because Coumadin has to deplete vitamin K clotting factor, so that you can't use that with Coumadin. But if you have, let's say for example, you have Xarelto. Xarelto is a 20 milligram once a day dose. If you were, let's say you've not had any AFib and all of a sudden you're in Mississippi taking place, and you feel your heart pounding and racing, and you know it's AFib, it would tell you to take the Xarelto right away, and effectively within 30 minutes you're protected. Not Coumadin.
No.
Yes, ma'am.
I had one of those Reveal link monitors put in.
We love them.
In December, everybody kept recommending it. I can't tell when I'm in AFib. What all are you going to do with the information?
So, we think it's invaluable for a lot of reasons. One is there's a number we get off of it called the AFib burden. So what is AFib burden? If you have a device, it's easy to calculate. It's the percentage of time that you're in AFib. So we can track progression of the AFib. Okay, that's important because if you don't have symptoms, then you don't know if the medicine you're taking has any effect at all. It could be worthless. Okay? And why do you want to do that? It's because if you don't intervene, there's a theory that your AFib may reach a point of, I hate to use the term point of no return, but it may not be treatable. Okay? So we think that information is extremely valuable. The downside of it is that people would, from a health economics, would say it's too costly. We can't do that for everybody. But if your practitioner is actually looking at it and using it to make clinical decisions, I think it's very valuable. The other point is that, let's say, for example, you have a link and you've had no AFib in 1 or 2 years, and you're in a low risk category. I think the decision making for stopping anticoagulants gets a lot easier.
Well, that was going to be my question, because you actually took me off the Propafenone, and it seems to be what was giving me side effects for 6 months, I've had like these bronchitis
Mm-hmm.
symptoms, and I've been through pulmonologists, couldn't find anything, and they said, one by one, try some of these meds. And since I've been off the propafenone, I haven't had any
Well,
problem.
propafenone has a little bit of what we call beta blocker activity, and a lot of folks don't know this, but beta blockers can trigger asthma. So a lot of the breathing difficulties or even cough can be an asthma surrogate. Even some of that could be from the beta blocker, and propafenone has about 10 to 20% beta blocker activity, so it doesn't surprise me you got better.
So if I am off of it and I don't have any AFib for a year or so, then I could maybe come off?
I think if your CHADS2 score is low, I think that's a very reasonable thing to do. You know, a lot of patients will ask me, what can I do? What lifestyle alterations or what can I do? Why do I have this damn problem? I got a great life, all of a sudden I'm in the EJ emergency room and I think I'm gonna die from it. What can I do to alter it? Is there anything I can do? And then you start getting on the internet and all kind of crazy wacko things come up. You know, take seaweed grass, or take this, or take that. Let me tell you what we do know. The strongest thing you could do to prevent AFib probably relates to weight. And I'm not just going to get on the gotta lose weight harp thing, because people misunderstand what I mean when I say you gotta lose weight. If you're overweight, a lot of the weight is distributed in the subcutaneous, subskin tissue. It has no effect on making you go into AFib. What is important is that when you're overweight, some of the fat accumulates around the upper chamber of the heart. And it's been shown that that type of fat produces chemicals called cytokines, and that directly triggers you into AFib. So if you were to do a CT scan or an MRI of your heart, and you've got a thickness of fat around the upper chamber, let's say like that, maybe just a few millimeters, and you go on a significant diet, and that shrinks, your AFib gets better. That's been done in Australia. In fact, the Australians have done a beautiful trial where for every unit of body mass index you drop, you have less AFib. So the single strongest thing you can do, if you can do it, would be to lose weight. Not easy to do in Louisiana, but if you could do that, it will have an effect on your AFib. Another important thing is that more and more, and it's related to overweight, is sleep apnea. Can't tell you how many patients we interview and we identify sleep apnea as an important cause of AFib. And if you don't treat the sleep apnea, you're not going to fix the AFib no matter what you do. It just ain't going to work. You could go in there and ablate the hell out of the heart, up and down, you know, like a lawnmower, up and down, it ain't going to work. There's something about sleep apnea. It's such a powerful trigger to the sympathetic nervous system that unless you treat it, it ain't going to get better. So I would say weight, sleep apnea. Third is, and it's much harder to quantify, but your perceived level of stress. Of all the heart rhythms, this is the one where the mind-body interaction is probably the strongest. Okay? Stress plays a huge role. A couple classic examples that Sharon kind of learned a little bit about when we started working with her. How many times have we seen an otherwise healthy patient come in? A lot of times it's a woman because they bear all the brunt of it, and all of a sudden they're thrust into a caregiver role. Okay, maybe some of you have been in that position. And all of a sudden your life aspirations are subjugated to somebody else. I can't tell you what a potent stressor that is. Or you've got a pain, let's say you hurt your neck or your back. That's a stressor. Many different stressors, but stress plays a critical role in AFib. So weight, sleep apnea, stress, diet, certain foods and certain people, particularly one of the strongest ones here is alcohol. Okay? And we've been knowing about the phenomena of AFib after binge drinking for years, but sometimes in a given patient, just one drink will trigger AFib. Some patients have a signature amount of alcohol. Now, caffeine may also fall in that category. We see in more younger people, you almost never saw a 20 or 30-year-old years ago have AFib. We're seeing more and more of them consuming energy drinks, and those energy drinks have super high caffeine concentrations, that may play a role. Some people swear to me, even some doctors, that if you go to a Chinese restaurant that has a lot of monosodium glutamate, that triggers AFib. So sometimes it's useful to keep a diet log and track your AFib and see if there's any correlation. So there's a lot of little things you can do, but if I was to say one single thing you could start doing right away would be weight loss. Stress reduction. If you think you may have sleep apnea, that's important. Identify stressors that you can control. Sometimes you can't. We've seen a small minority of patients where they're so anxious that anti-anxiety medicines help them. So I could go through a whole list of things that you can do homeopathically to self-treat AFib. Okay? If you get on Google, you'll find all sorts of promoted things like coenzyme Q10, certain vitamins. So what do we know about vitamins and supplements? We know that, for example, coenzyme Q10, particularly if you're on a statin drug for cholesterol, supplementation may have some beneficial effect. We know if your vitamin D levels are low, that may have a beneficial effect. I can't find any benefit for vitamin C or vitamin E, but of the two big ones nutritionally, I think coenzyme Q10 and maybe vitamin D, if you're vitamin D deficient, may have a role. Some patients swear that if they've gone through stress reduction programs, that helps them. Some patients have anecdotally reported to me that if they go through yoga or meditation techniques, particularly transcendental meditation, if you have the patience to go learn it, and you have a good practitioner that will teach it to you, there's definite data on transcendental meditation decreasing AFib. Zhen could probably tell you 100 remedies from traditional Chinese medicine that has been promoted too. But so there's a whole lot of good things you can do. I think if you're into supplements, it's a good idea to pass that by your doctor. So because a lot of supplements have herbs that are actually pro-atrial fibrillation. So if you're going to get onto the nutritional dietary kick with that, you might want to screen us to let us look at it. But I say caffeine is a big one.
Chocolate.
Yeah, chocolate, you see, if you got good chocolate, like I went to Belgium a few years ago, they got really good chocolate.
Yeah.
Dark chocolate, not some of the stuff that's sold, dark chocolate's actually been shown to have some beneficial effect in AFib. Because the rich antioxidants of the dark chocolate, the antioxidants may have some beneficial effect. So it's a loaded question because chocolate also has theobromine, which in some patients can trigger AFib. So I'd say good chocolate maybe is a good thing.
Yeah, red wine was supposed to be heart healthy too.
Yeah, the trouble with red wine is that a lot of times it's contaminated.
Yeah.
If you look at sulfites and you look at some of the things in red wine, there's some contaminants. Resveratrol, which is the active ingredient, may have some benefit as an antioxidant, but the direct effects of alcohol outweigh, because there are people who, at a signature level of alcohol, they're going to go into AFib. So it's outweighed, I think, by that consideration. So I mean, this is one of my interests because a lot of patients will ask me that. They do a lot of research and they ask me some really good questions about, what about this? What about this? There's a lot of dietary things out there that are promoted to be anti-fibrillatory. But the hard data behind most of those is usually pretty nil. So you got to be careful.
When the lady was talking about a loop recorder, I have one as well. Is there a percentage you look for that becomes a trigger for you to be concerned on how much somebody's in and out of?
One of the big debates in AFib right now is at what level of incidentally detected AFib do you have to worry about blood thinners? And the other thing is at what level of AFib do you worry about progression? We don't have good answers to those. I think above 5 to 10%, I start thinking about alteration of heart rhythm drugs. Because this idea, you've heard the idea that AFib begets AFib. So this has actually been well studied. If you take, the original studies were in goats, I think, in the Netherlands. If you induce AFib, and then you convert the animal back, AFib actually sets in motion changes in the upper chamber that make the AFib easier to go into. So there's actually biochemical changes in the atrium that once you've had your first AFib episode, your body is set up for another one. Vice versa, if you break the cycle of AFib, those changes tend to reverse. They never go back to normal. So once I like to use the analogy, the genie's out of the bottle, it's hard to put the genie back in the bottle. So I tend to be aggressive up front. And there's a theory that there's a point of no return. At a certain duration of AFib, after you've been in it for long enough, there may be some point of no return where nothing you do is going to work. Now, I'll tell you some insight we've gotten into our procedures, is that when we go into the heart to go do our procedure, we're one of the few groups that actually maps. By map, we mean we take a catheter and we measure the voltage, the internal voltage of the heart, and you can display that on a mapping system. Maybe next time we'll show you some pictures of those. And what you find is that in some patients, there's so much damage to the upper chamber. So we depict low voltage as gray, that almost the entire atrium has no voltage. It's a very sick, unhealthy atrium. And what we find is no matter what we do in those patients, nothing tends to work. On the other hand, we've got some patients who've got incredible amounts of AFib. We go in, the atrium is healthy, the voltages are high. Sick tissue has low voltage, healthy tissue has high voltage. Those patients, they have very good results. And if you look at the literature, there's some corroboration of that. So in general, the more unhealthy the atrium, the less likely the procedure is going to be to work. In fact, we can almost predict in some patients who it's going to work in.
Can you predict that before the procedure?
Yeah, that's a good question, actually. That's a good question because there's a group in Utah that kind of pioneered this work, and what they do is they use a special MRI, magnetic resonance scan, with some special software, and they can measure non-invasively the amount of scarring in the heart. The fellow's name is Nasir Marouche. He's at University of Utah, and what he's found, and there's some question about, some people don't believe it, but I do believe it, that the more scarring in the upper chamber, the less likely the procedure is going to work. So they call it Utah Class 1, 2, 3, and 4. If you've got so much scarring of the heart, they call it Utah 4. That means the heart's scarred up. Nothing you do is going to work.
Can you measure that here?
No. Nobody in New Orleans has that capability. It's investigational. I've had a couple patients fly themselves to Utah and get the scan, though. One you know very well.
Yes.
So that's going to be the future. You're going to be able, because we don't want to put anybody through procedures, okay, that not going to work. There's nothing worse for us, and he'll tell you the same thing. There's nothing worse for us than putting kind of our heart and soul into a procedure, working as hard as we can, to come back 6 months from now and tell you that the thing doesn't work. I can tell you, me personally, that's the worst feeling in the world. So the question you have, is there a way to predict beforehand who's going to get benefit? And the answer is possibly yes. But we don't have that capability. Delayed enhancement MRI is available here at East Jeff, and it's available at Austin, but the special software, the investigational software, is proprietary, and they're going to try to sell it, which is why some people criticize the group. They think there may be some self-serving motivation in it.
Are there any other diagnostic symptoms prior to the procedure that help give you a clue as to the likely outcome?
Okay, so age is a negative, but not in everybody. We know that the bigger the atrium, the more ballooned or big it is, the less likely it's going to result in a success. We know if you measure the pressures in the atrium as you go in to do the procedure, elevated pressure in the heart is a bad sign. There's a bunch of little things, but those are the big ones. COPD, lung patients don't tend to do as well. We shy away from doing anybody with severe lung disease. Renal disease, if you're nearing dialysis, it may be a negative sign. There's a whole host of prognosticators. The trouble is, there's no single thing that tells you with high predictive value. They all have a sensitivity and a predictive value. There's no single predictor. There's a lot of little things you piece together, and we kind of put them together in our minds. That's a good question, because what you're trying to say is, why should I put myself through a procedure if there's technology to tell me it won't work? That's where we're headed. We're headed toward that point where one day I think we will tell you that. We just don't have it 100% here now. Yes, ma'am?
How long from the time that you go into AFib do blood clots begin to form?
Another great question. It can be as short as 6 to 12 hours. It usually has to have some finite period of time. But there have been studies where it can be as short as 6 to 12 hours.
For the review design, when you talk about Medtronic people, why they design how we monitor the A-Fib episode? They give the cut line is 2 minutes. That means if you have A-Fib longer than 2 minutes and the machine think about its irregularity, they record this episode. So this data, they come from the old study from the Holter monitor, 5.5 minutes can report, case report for stroke. So whether it's true or not, and nobody know that. So Medtronic try to put as much as possible in the future and to see whether the 2 minutes is the cut line, or 3 minutes, or 4 minutes. Currently, they don't, but they have us design 2 minutes for the review.
I don't personally believe that. I think it's got to be longer. I think one of the things that's been a revelation to us is that with the event monitor data, you would think that you would go into AFib, the clot would form, it would fly out to the brain and cause a stroke. What they found in some studies was just the mere presence of AFib had no time relationship to the stroke. So what that means is either the AFib is causing the clot to form and the clot kind of incubates in the appendage, or there's something about the fact that you have AFib makes your blood more likely to clot. To me, that's a big revelation that you can't always use the timing of the AFib to predict the stroke risk. There may be something else going on. And if you're interested in that literature, I think it's fascinating, but it's a big surprise to me.
When we have these monitors, does anyone call us if we're in AFib for a long time?
Okay, and great point. Poor Sharon has had that.
Because I don't know.
We're going to give Sharon a Sainthood Award one day. People get very angry at us. We're nice people. We shouldn't get angry at us. People get very angry at us because they believe that there's a human being at the end of that recorder. I hate to say it, you could drop dead and nobody would know it with a link recorder. I'm serious. There's no human being watching it. What happens in the link recorder is it puts it into its buffer. When you go by the device, it downloads it, and then it's sent out. Somebody may not look at that report for days. Okay?
I'll
So
explain it after our process.
there is no human being at the end of that yoke. Okay?
I'll tell you.
Does that make sense? And so what we do is we accumulate the data. She shows them to me every afternoon on Tuesdays and Fridays, and we'll look at the AFib burden. If I see a lot, we'll call you back in.
Oh, so you get it?
No. So we don't always get it. If our group puts it in, the way Medtronic has it set up, I don't put them in. Dr. Jiao puts them in. If Dr. Jiao puts in a device, the report comes back to us. If Dr. Bourgeois puts in a device, it goes to them. So we have to formally request, and there's a HIPAA process we have to go through, a legal process we have to go through to get that report back to us. But there is no human being watching that, okay? Now, if you have a wearable monitor, let's say a 30-day monitor, there's a human being watching that all the time. And believe me, I know I get the 2 o'clock phone calls. So there's a human being, but the implantable device, although it's incredibly useful, there is no human being there. Literally, you could die, nobody would know.
Yeah, I was wondering though, I mean, short of when I come in 3 months.
Yes, to answer that, yes, it's looked at. It's looked at every month. A report is generated every month. And if Dr. Giles puts them in, he puts measures in there. And if there's a AFib over a certain period of time, whatever he puts in, we will get that, which we look at every, like twice a week. Okay.
It's going
Yes.
to depend on what you set up.
Yeah.
Some people in the review, you can set up any AFib, that means any AFib longer than 2 minutes, or 6 hours, 12 hours, 24 hours. So it's depend on the input doctor, which duration you put. You maybe have 2 hours AFib, but if they set up 6 hours monitoring and report to doctors, you will miss that episode.
I'm going to take your question, but I want to make you aware of another technology that's very useful, because a lot of times a lot of patients hate wearing monitors, and monitors are very expensive. In fact, I think they're a ripoff most of the time. we're not financial, we have no financial involvement with the monitoring, it goes to another company. In fact, me and Jen, we're employees here, we don't, we're not ordering monitors to run bills up. But we need the monitoring information sometimes a lot. For example, we'll start an antiarrhythmic, how do we know it's working? We have to monitor. We have to change the drug, we gotta monitor again. There's a home monitoring system you can buy on Amazon. It's called a Cardia device. I know some of you have the Cardia device. And if you have symptoms, you can track whether you're having. I think it's a very useful tool. It's a forerunner of what's going to be what's called wearable monitoring. And that's the future. And it's very useful. The trouble is if it happens during sleep, we don't know. And if you're asymptomatic, it doesn't help you a whole lot either. But for some patients, the Cardia device can save you a lot of monitoring. Jenny?
They work with the Apple Watch. I think
Yeah.
the Apple Watch is work with this company.
Yes, Apple Watch
Yes.
is
They
approved.
give you a monitor and give you alert, and so you call 911 or call your physicians.
And that's the future because, listen, the medicine's getting so expensive. We got some patients on fixed incomes having to take new anticoagulants. They're on medicines for heart failure. They're on antiarrhythmics that are expensive. The cost of monitoring is astronomical. What's the cost of the event? It's $3,000 if you
That thing here at East, the
Yeah.
events,
What's an event monitor cost? $3,000 at least?
I don't think I think maybe 1,700.
It's still expensive.
This one I had put in, I saw the bill was
Yeah,
38,000.
we're talking about the monitor, not the info.
Oh, okay.
Yeah, but nobody pays
But I was
that.
gonna say, I don't know.
That's the hospital. That's not Dr. Zhao's fee, I can tell you.
No, his is 700.
In my case, my monitor is built into.
Well, if you got a pacemaker or a defibrillator,
Yeah.
that's golden.
And
We
I
get a lot of
get a
information
call
from that.
every 3 months,
Mhm.
and they'll even tell me how many hits I had, and I never felt them. I mean, for 2 years plus, I haven't had the defib go off, and I don't know when I'm having.
Yeah, that's
And
a
the
good,
woman in Tennessee, wherever, will call me and say.
that's a good point, because if you've got an implantable device, you've got an implantable monitor. You don't
Yeah.
need a link
And
device.
then that goes to my doctor
Yes.
here.
That's right.
So, to your knowledge, is there a way that you
I'll
can
come-
work
I'll
out a
get to
deal
everybody.
with Medtronic that you would be able to download that data directly at home through an app or something, so you can
That's
monitor your own
that's where it
information?
should come to. Dr. Zhao was talking about Apple Watch.
Uh-huh.
Apple's a very innovative company now with trying to get into the health care field. You'll be able to put all your medical records on Apple Watches, for example. He's talking about the Apple Watch being able to automatically detect and use algorithms to tell you when you're in AFib, like a warning, for example. But there's no way right now that you could download that. You want to download it for your own personal use.
Yeah, from Medtronic, say.
Yeah.
Well, I know they're working on the ability to transmit it to a cell phone. It's not available yet. That'd be very useful too.
Yeah.
My internist and Dr. Bourgeois mentioned an app you can get on your phone that does an EKG for you.
That's called Cardia,
Cardia.
K-A-R-D-I-A. You can buy it on Amazon for about
Yeah.
$100. You gotta be careful because they try to trap you into their subscription, which is not a bad thing, I mean, because it does give you automated interpretation, but it is a way for them to make more money on it. I mean, what we want is something
Wow.
cheap. Okay, we want every AFib patient to have something, because most of these are rip-offs. You know, if you're monitoring for AFib, it shouldn't cost you $1,700 a month. It should be nominal. That's where we think something like an Apple Watch that could do that is gonna be good. Yes, ma'am. I'm coming back to you.
This may be a duplicate of his question, but I have a pacemaker, so how does the pacemaker compare with the monitor that they're talking about?
How does a pacemaker compare to a link device?
Yes, because when I go in, you read and tell me, or they read and tell me.
Yeah, a pacemaker, particularly if it has 2 leads, is very, very accurate. A little bit more accurate than, say, a link, but not by much.
But it's just monitored when, I mean, it's just,
What it does, it's got an internal counter,
uh-huh.
and when it sees it, its algorithm is actually very good, and it will basically take that episode, tell you when it started, when it stopped, and put that in a little bin. And we give you the printouts of those, right, where you can see them. It's very accurate.
So, but if I don't come in but every couple of months,
Who's watching your pacemaker?
nobody.
No, who put it in?
Oh, you all did, Dr. Zhao did.
Dr. Zhao put it in? Then we may be watching it.
But not all the time, not 24/7.
Not 24/7,
Yes, sir.
but once a month.
Is the, you said we're talking about the anti-arrhythmia drugs, that they can cause a rhythm problem in the lower chamber. Does that feel different than the upper chamber in terms of the sensations of the patient?
Not always. That's the problem. It's felt that, I have to be careful how I say this. It's felt there have been far more deaths with the treatment of AFib, with antiarrhythmic medicines, than the AFib could ever cause. And there have been more deaths because of antiarrhythmic drugs than any procedural approach. It wouldn't even come close. Because remember what happens is the doctor who prescribed it may not even know you had a bad outcome. You just don't show up in the office. Death can occur with antiarrhythmic drugs. And it's not a zero problem. It's estimated to be as low as 0.5%. But it could be as high, for example, if you would take one of the older drugs like quinidine, it could be as high as 5%. Drug like sotalol, we don't know. It could be anywhere from 1 to 2, 3%. We had a young woman die on sotalol. Yes, sir.
Doctor, I was forced to go to orthopedist because my knee was giving me trouble when I'm painting the room in my home and getting up and down the ladder, you know. So orthopedist, I'll take care of you, son. He's actually older than I am. Oh, very helpful and good doctor. So he comes in and gave me a shot, one of the longest needles I've ever seen, other than epidermal. And he said, ask your doctor. So Dr. McKinnie, so he's the best. Ask him if you can take a steroid once or twice a year to help your knee.
We get asked that a lot. Do steroid injections cause AFib?
They do.
We get asked that question a lot. I think in some patients, you know, anecdotal experience is not really good experience, but I've seen too much of it to discount it. But let me give you an alternative hypothesis on that. You had a lot of pain. That's what prompted the steroid injection. Pain by itself can cause AFib. So was it the steroid injection to alleviate the pain, or was it the pain? Let me give you another example. Patients around the end of the year, so much pneumonia, flu, and bronchitis. Everybody's gulping down decongestants. Decongestants are a major source of AFib around the holidays. So, I mean, is it the primary effect or is it the secondary effect? I think it's the secondary effect.
Let's go on. Better to use ice.
You're going to be a cryo proponent. Yes, sir.
Is that portion of the heart that causes the accumulation of blood clots, is that an essential part of the heart? Is it a function, or is it like the appendage?
You know, there's a whole conference about the appendage, and about, I'd say 25% of that is due to what is the function of the appendage. It's probably a way to modulate pressure in the heart, but you can take out the appendage and have no ill effect. In fact, some people do that as part of their AFib ablation. They'll do the appendage resection through a different technique, then come back and do the other procedure. At University of California, San Francisco, they're doing a clinical trial with that. Andrea Natali, who's one of the top AFib experts in the world, as part of his AFib procedure, he will ablate. He'll take the ablation catheter and ablate all around the appendage. Now what does that do? It makes the appendage non-functional. So what do you have to do? You have to come back and put an occlusion device in. He says his results are better with that. Of course, then you got to have another procedure on top of it. So what you ask, what is the function of the appendage? It's probably a way to modulate pressure changes, but it's not essential. Somebody in the back I missed? Okay, we've inundated you with AFib. Any other questions?
Just want to say one thing, is that they have a question?
One more question.
What kind of anesthetic do they use in these procedures?
Okay, so in Europe, they use conscious sedation with Versed and fentanyl more often than we do. Almost all of our patients is under general anesthesia, mainly for patient comfort. You don't have to do that, but it's more comfortable for patients to have it. Yes, ma'am.
Dr. McKinney, do people, I read on the internet that sometimes if you have, esophageal issues, that could deter from.
Hiatal hernia. Hiatal hernia is well described, particularly a big hiatal hernia. You gotta remember the esophagus runs on the back of the atrium. It runs right down, in fact, we try to avoid it. So a big hiatal hernia is a known precipitant of AFib. Reflux is a known precipitant of AFib. Stomach distension is a known precipitant of AFib because of the vagal nerves that innervate the stomach.
But how does that affect having, say, the conversion procedure or,
A hiatal hernia.
well, the esophagus issues?
Okay, so let me just go over one thing about the esophagus. Where can you get in trouble with procedures? The esophagus runs right behind the back wall of the heart. Okay? If you are mowing your lawn on a Saturday afternoon in 80 to 100 degree heat, and you go chug a big slug of cold liquid that goes down the esophagus, it can trigger AFib. Okay? Likewise, when you're on the inside of the heart, and you're burning or freezing, the esophagus is right there. There have been several deaths in Louisiana by people doing catheter ablation using the burning technique. That's why we don't do it, or we don't do it as much. It's called an esophagus fistula, where you can actually burn a hole through the back wall of the atrium into the esophagus. The two form of communication, which is horrible. And then you basically, esophagus contents get into the heart and they're propelled up to the brain. So death with AFib ablation is probably the biggest proportion of that is due to atrial esophageal fistula. You may see that term in the literature. It's very unusual, but it has happened, and it's happened here locally. That's what prompted us about 8 years ago to move away in this setting here at East Jeff to do the cryo, which I think is safer. But there have been reported fistula with cryo. So there's no technique with zero. We think it's less. When you do one of these procedures, a lot of times you'll get some irritation in the esophagus with cryo, but fistula is pretty rare. The other thing you can get after cryo is the bronchi run right on top of the heart surface. You can cool the bronchi and you get a cough for about 4 to 6 weeks. Those are minor side effects, but every side effect is a side effect.
You saying reflux can trigger AFib?
Any pain can trigger AFib. We see more hiatal hernia trigger AFib, particularly a big hiatal hernia. We've had a couple patients who've had hiatal hernias resected and the AFib went away. I'm not saying I'm not saying we should use that as a cure for AFib, but we've noticed that. Big hiatal hernia, because of its proximity to the heart, can do that. Well, we're giving you a lot of info tonight.
Yeah.
Has anybody here had a Watchman device implanted? Anybody have the Watchman occlusion device? We sent a couple people for it. All right, so 2 months, if you have any particular topic, if you want to do it, I was thinking about stress reduction techniques, if anybody's interested, because that's a hot topic. Or we can do nutritional aspects of AFib, or we can do a review of the antiarrhythmic drugs. We'll do whatever you want. Just tell Sharon what you want to hear about, or we can mix it up.
Dr. Jiao is going to conduct a transcendental meditation
Thank you.
session.
I've had so many patients who've told me that.
It makes sense.
I'm not a
Stress
practitioner of it, but I've had too many people tell me that they've gone through not just TM, it's a variety of different mindfulness or a number of different techniques that they feel that the stress reduction technique has significantly lowered the amount of AFib. Now that could be a placebo effect too, because if you believe in something enough, sometimes you have an effect. But I've heard too many patients tell me that. Now, not everybody's out there going, but there are people now that are learning those kind of stress reduction techniques. There's a whole host of them. Sleep quality. If you have poor sleep quality, it's horrendous for your AFib. A lot of times as you get older, your REM sleep levels go down. There's been correlations of improving sleep quality with AFib. So we could talk about hours about all the different things in the literature, but there's a lot of stuff you can do. Okay, folks,
all I can
two
digest
months.
today.
I do know that some people brought up some things. I want to invite everybody to visit that website. Dr. Jiao gave a talk last year on the occlusion devices. So his talk is archived there. And Dr. Brothers gave a talk on the convergent, but there's others, everything's on A-Fib. So if you visit that website, some of the things we talked about tonight, they had specifically for that, an hour-long presentation.
A lot of people ask me about what's new in drug development. It's horrible. There's nothing. There's nothing, and the reason is because some of these drugs cause problems in the lower chamber. Companies are afraid to develop them. There's absolutely nothing in drug development right now I can point to. A lot of patients say, is there anything experimental I can take? Not much.
No, I was not.
But if you're interested, you can go to clinicaltrials.gov and you can look up every clinical trial in the United States.
I have something second.
Okay, we're good. The convergent data is on there too. Dr. Jiao gave.
Dr. Jiao talked about